Stand on the existing protocol and proceed by quickly congratulating the ARD, Association of Resident Doctors, UPTH branch, ably presided over by our own Dr. Diamond and all the other executives. Also, I want to congratulate the Burns Society of Nigeria. Burns Society of Nigeria, ably presided over by Dr. KJ here in UPTH. And UPTH, the hospital community, I want to congratulate all of you for this. I consider this symposium as not just timely, but of a huge relevance, in our society that is rapidly developing, and considering the events that have taken place in our own state in the recent past. So I think there couldn't have been a better time to have a symposium like this, to create this awareness and impart knowledge on all of us. In AstraZeneca, we are not relenting in the fight against infections, because we know that for burns patients, one of the biggest challenges the burns specialists have to face is managing overwhelming infection in burns. And for that reason, we are not relenting in our efforts in making great medicines not just available, but also affordable for our patients who may be needing them. So today, in 10 minutes, I'll be sharing with you what we are doing, what we've done in terms of patient access program on some of our great molecules. And I'll also be addressing a little concern that has come up lately. I think I'll be needing my slides now.
I'll just bring to your attention news that has been making the headlines lately. Only yesterday I heard, for those of you who fly a lot, that Arik Air has been grounded. And just before that, another airline was equally grounded. And I began to wonder, what shall we do? It may just be a wise idea to carry you a trash bag full of Damji, a lot of antibiotics, povidone iodine, and stuff like that before flying these days. You never know. You may need it while you're airbound or just before you land. Somebody say, God forbid. God forbid. All right.
Sorry for that interruption, and thank you, MC, for lightening up the mood. Okay, I go on. It is no longer debatable that Meronem, our life-saving antibiotic, has established itself as your number one choice when it comes to overwhelming, difficult to treat stubborn infections. And for that reason, Meronem has become a household name whenever doctors run into problematic infection. Let me go. I'm sure you're all waiting to hear the good news. The good news. Just get ready. The news is on the way. Thank you. So the good news. Just hold it there. So we did a patient access program on Meronem based on all your concerns and objections around the price. And this is what we come down to. Yes. Over 20% reduction in cost of Meronem. So Meronem no longer gets to the patient at the price of 8.5 for the 1 gram bar. No. No more 8.5 in the hospital. It now goes to the patient at the price of 6.5. I'll get an outcome. Yeah, I mean, it can only get better. Considering where we are coming from. Some of you know where we are coming from. And look at where we are now. So things can only get better. And I'm sure that some of you might be wondering, what has changed? Did we change the Meronem? How come the price slashed? Now, I'm going to tell you, nothing has changed. It's still that same Meronem that stopped pathogens from taking your patient. That your patient that had severe bronchopneumonia in the hospital. That same Meronem that stopped pathogens from taking that your patient that had widespread peritonitis. That same Meronem that stopped pathogens from taking that your patient, taking the life of your patient that had overwhelming sepsis, and you had tried so many other things, and you were not getting good response. But immediately you brought in Meronem, you had a dramatic response. It is still that same Meronem. And there is a science behind this magical response you get with Meronem. And that's what I'm about showing you. No, go back to the book. Yes, this is that one. Just hold it there. The excellent qualities you're looking for in an ideal antibiotic, what are they? You want spectrum coverage. Meronem does not just give you broad spectrum coverage, it gives you ultra broad spectrum coverage, giving you coverage of gram-positive, gram-negatives, and anaerobes. So it presents itself as a convenient choice, as a monotherapy, in a wide range of bacterial infections, talking about polymicrobial infections, mixed infections, and you don't have to combine. That is the beauty with Meronem. You don't have to combine with metronidazole. You don't have to combine with gentamicin, because Meronem gives you adequate coverage on all the likely pathogens that could be responsible for that infection. So Meronem is the convenient choice as an empirical treatment when you face a challenging bacterial infection. Not just coverage. The same Meronem gives you a potent bactericidal effect on even stubborn pathogens that are resistant to the conventional antibiotics. Talking about the cephalosporins, talking about Pseudomonas, Klebsiella, multi-drug resistant E. coli. The same Meronem gives you excellent coverage on all of these with a powerful bactericidal effect. Remember, it is the same Meronem that penetrates well into virtually all body organs and tissues, getting to the site of the infection, wherever the bug is hiding. It hits hard on the bug, delivering a quick resolution of infection for you. And this makes Meronem difficult for bacteria to resist. Now, you might be wondering, with all this potent, antibacterial effect, how is the safety of Meronem? Now, I'm pleased to inform you that despite the high potency of Meronem, it has excellent safety profile. And the safety profile is similar with what we have with the cephalosporins. Being well tolerated in adult patients, well tolerated in pediatric patients, also well tolerated by the CNS. And currently, Meronem is the only carbapenem that is approved for meningitis. So when you have a difficult to treat meningitis, the cephalosporins are not working, the penicillins are not working. The only choice you have to step up to is Meronem. And trust me, we are having excellent testimonies. I just got a call from a doctor this morning with one of the mind-blowing testimonies on Meronet. And that set my courage as I was coming here. Ladies and gentlemen, when you are faced with a life-threatening infection, a lot of things are at stake. The life of the patient is at stake. Your profile as a doctor is at stake. The profile of the institution is at stake. You cannot afford to get it wrong. You have less than 48 hours. And all you need to get it right is what you have in Meronet. So please stop wasting time. Get that patient on Meronet and get it wrong. Thank you. I said I would address a little concern. Please, you may allow me. Have I exhausted my time? 2 minutes. Okay, so something happened there some time ago. I walked into the consulting room to talk to a doctor about Meronet. And when I started, he said to me, "Is this the main Meronet?" I said, "Yes, it's the main Meronet." He said, "No, but that someone came to him not long ago, telling him that he has something that is like Meronet. And unfortunately, he hadn't heard of Meronet. And the person was telling him, look, what I had is like Meronet. And he was like, Meronet? What is Meronet? So when I came, he was like, oh, this is the real Meronet now. Now, something is going on. And maybe some of you may have encountered people telling you, we have something that looks like Meronet. Please, if Meropenem is not made by AstraZeneca, it is not Meronet. It could be any other thing, but it is not Meronet. Just one more thing. I was talking with a consultant the other time, and he told me that when you want to wire a house, there are two kinds of cables you could use. There's a China-made cable that goes for about 2.5 for a bundle. There's also a locally made cable that goes for about 7,000 for a bundle. Now, the risk with using the China-made cable is that the occupant of that house is that a danger, a risk of having the house blow up or its appliances blow up with the China-made cable. Now you're paying less, or you're running into greater risk. So whenever you're paying less, please watch. You might actually do. Thank you very much.
I think we will just take a few more questions for the drug reps so that they can address the questions together. You mentioned one already, dosing. So do we have other persons who have questions for the drug reps? Few questions.
I believe we should still look into the issue of cost, because it is not sufficient to stand and condemn the products from other companies. Doctors are getting results from them. So if you want yours to remain the gold standard, the issue of cost still has to be addressed. You don't expect the patient to cough out 6,500 times 3 in a day. I don't know how many Nigerians can afford that in a day. I remember this, a medication that's going to be given for some days. The effect is tasking on the pocket of the patient. So you have to put that into consideration. I am not convinced that we should only be looking at your Meronet. If you want us to look at your Meronet only, then your company has to do something about the pricing. Thank you.
My son is the empirical administration of antibiotics. That's the particular area. When 10,000 came, everybody for every case, everybody prescribed. And today we're getting worried. Nobody does anything. So nobody does anything. That's do sepsis, don't prescribe therapy. Now Meronet has gone. I think we get microbiology to really talk to us about what is the specific pattern of organisms in this environment and its response to Meronet. If we don't do that, I will keep prescribing Meronet. Tomorrow we want to talk. I think you guys should work with microbiology, with clinical microbiology. So you get better.
We'll take the responses from the drug rep.
Okay, thank you very much for your questions. Let me start with the doses. Meronem is given at a dose of 500 milligrams to 1 gram 8 hours, depending on the severity of infection. In adults, 3 times a day. For pediatrics, we recommend a daily dosing of 10 to 20 milligrams per kilogram 8 hours. But for meningitis, we recommend for pediatrics a dosing of 40 milligrams per kilogram 8 hours. And for adults, 2 grams 8 hours. It is not more expensive than life. People pay 1 million to get a child. In a procedure that is only 30% success. Now this is the one you have already, or someone that is close up already. It's a life-saving drug, and it's not meant to be used routinely. You use it when chips are down. When it's a matter of life and death, you use Meronem and get the patient back to life. So that's for the dosing. Now, the concern my able consultant raised, he happens to be my very good friend as well. So I'm sure I didn't run down any product. I was just trying to let you know that branding is important. You know, you don't come and say that this is like the other brand. Your brand has a name, so market it with the name. You understand what I mean? Yeah. So if you go, you say, talk about your brand, leave Meronem out of the picture. So when people keep referring that it is like Meronem, because they know that it is Meronem you will prescribe. So that's just the concern I was trying to address. Not in any way. Of course, the need for generics cannot be overemphasized, considering a society like ours. But of course, we cannot kick away the innovator brand. Knowing that most times when the chips are down, we run to them. Okay. Let me take the last comment. So he talked about empirical treatment with antibiotics without having, should I say, microbiological investigation. Actually, I've been working closely. I think if anybody in the microbiology department is here, the person would bear witness that I've worked closely with them. I've had seminars of Meronem with them. I've even provided them Meronem sensitivity discs that they are using to run some of the stubborn pathogens. Okay, so we are working closely with them. But you need to know that when you use empirical treatment, the diagnosis is still not definite. That's why it's called empirical. So at that stage, you don't know what you're battling with. You don't even know the resistant pattern of the organism, like you said. So what you don't need to miss your target the first time, because it might be too late to bring in a second one. So you need to use your strongest arsenal when it is a life-threatening infection. When you have your microbiological result, you can de-escalate. I believe some of us are already practicing the principle of de-escalation, and they are getting good results from it. After 2 days or 72 hours, you could, reassess your patient and change your course of antibiotic treatment. So that's what we recommend. Thank you.
I'd like to know the major side effects that can encounter with use of this drug and how available it is, the drug, and then the route of administration.
Apparently, you've not been in any of my Meronem presentations. Okay. Sorry, my presentation was so concise because most of you here have heard it before. So I didn't want to bore you with the whole details over again. So that's why and I was told I had 10 minutes. So I prepared for 10 minutes. Okay, so forgive me for not giving you all the details you need. But as for side effects, the commonest side effect with Meronem is inflammation at injection site. That is seen in less than 10% of the patients. That is the commonest. The other ones are seen in between, 1% and less. We talk about, of course, nausea and vomiting must be there somehow. And we talk about some biochemical changes in the body as well. So, but as for inflammation at infection site, and then diarrhea too comes up a little sometimes. Those are the ones you watch out for. but it is a well-tolerated molecule, I can assure you. Okay, route of administration is IV only. It's only giving IV by bolus injection or a short infusion of about 30 minutes. So you can use water for injection to reconstitute and give over 5 minutes as a bolus injection, or you can run an infusion for 30 minutes with normal phalanx. Thank you.
Thank you, AstraZeneca, for your presentation. A trial will convince those who have not yet tried, isn't it? Yes. I would like to recognize the presence of the head of department, obstetrics and gynecology, Dr. Cosmos Einda. Please come to the front, sir. Put your hands together for him. I also like to recognize the presence of all other consultants present here. I can see Dr. Pibai is already in front here, and he was smiling when he talked about, when the AstraZeneca guy talked about 1 million naira for IVF. That may even fail. I also like to recognize the presence of our media partners present here, AIT, Cool FM, STV. Let us please put our hands together for all of them. You've done very well. It's now time for the main lecture. If you take a look at your program of events, it's lecture number 4, current concept in the management of bonds. And it's going to be taken by Dr. BMKJ again. So while he prepares to come to the stage to give his presentation, I'll just share with you my experience. A few years ago, I lived very close to major pipelines in this state. And I noticed several young men were always going down there to vandalize the pipes. And then they come back with 50 liters of diesel, 50 liters of petrol, and they sell it. They have some pool money. I was tempted. I was very tempted. Would you like to know why I did? No, I didn't join them. I nearly joined them. I didn't join them. On this particular day, a pastor who also lived around the area, he had serious issues, financial issues, no tithes, no offerings coming into his church. He had a family of 7, he was very hungry, and then he decided to join those boys. So they went to vandalize another pipeline, and then they started fetching the products. And as they were about leaving, JTF rounded them up, shot the pastor in the hip. And as they shot him, the petrol he was carrying caught fire. He got burned, and he presented here. So I didn't join them. So it's really not about hunger or poverty, I think. Maybe it's just human nature to be greedy. I don't know, maybe I'm wrong. Everybody gets involved. Even the doctor was involved sometime in pipeline vandalization, and he was caught. I had to go and bail him. I emptied my account, my savings to bail him. He knows himself. He's even here. But I won't mention his name.
Were you in partnership?
No, not at all. It was just out of my goodwill I had to go and bail him. I bailed him with a very huge sum of money. It's a joke, oh, we're a kidnapper here. Shishi, I don't get it. Throw.
Good morning again. Please permit me to stand on the existing protocol. I bring apologies from Dr. Uburo, who is the president of the Nigerian Bond Society. He's a lecturer, senior lecturer in University of Lagos University Hospital. And just this morning because of the problem with the airline. It was difficult for him to get a place to travel. So he pleaded that I should apologize on his behalf. And then, because you are here, we have to go on to talk about this very important topic. And I assure you that by God's grace, we are going to get a good money for our time. Thank you very much. Management of burns. One of my colleagues will talk about the prevention. We talk about prevention, and at the end of this my lecture, I would also mention briefly about the experience of Okugbe. One of our residents was supposed to also take that, but we just heard this morning that he was also held up and cannot make it to this place. He's not in the state, or just could not come because of perhaps the airline problem or whatever. Managing bonds.
Professor Alice Inter, I saw her walking a few minutes ago. Please put your hands together for her. My able prof. You're welcome. Please, after the registration, you can come forward. God sits here for you.
Very much. Just go on. This is where we are today. I'm delivering this lecture, and the outline will be introduction, the epidemiology, anatomy of the skin, management, mechanism of burn, pathophysiology and pathology, form classification, that is, the depth and the surface area management, the emergency assessment, primary care, fluid resuscitation, wound management, surgical procedures, complications, prevention. Somebody else is talking about prevention. The skin is the largest organ in the body. And so anything affecting the skin is actually going to affect the body very well. Burn ranks amongst one of the most severe trauma in medicine. Is defined as a coagulative necrosis of the skin and the underlying structures. Sometimes it results in the destruction of the skin and consequently opens up a large surface area through which there is loss of water, loss of electrolytes, loss of protein, loss of heat, and then microorganisms can easily go in and out and invade the body, breaking ways for the use of antibiotics. Epidemiology, we are talking about Nigeria, and we hope that with time we are going to get the real figure about the affectation of burns in our society. But you agree with me that in the recent times we have been seeing a lot of burns, a lot of kerosene explosion, a lot of petrol explosion, and so on, that it must be a cause of concern. Pipeline ruptures or pipeline vandalization have not actually helped the matter. The mortality rate is very high in our country. While Australia, for instance, records about 1% mortality, we are recording about 30. In upth, we are talking about 33%. Well, we could say because of the mechanism of burns, we have much more of the higher percentage of burns. And of course, that will give us higher mortality. It affects the patients psychologically and physically. There is a high financial involvement in the management of burns. It's a burden to the nurses, a burden to doctors, a burden to relations, and everybody around. The complications and after effects are long-lasting and often with chronic disability. Somebody with burns, after 30 years, you will see with his scalp. When there is a deformity or a disability, it lasts very long, and it takes a lot of money to correct and rehabilitate. It can occur at home, it can occur on the road, in the industry, and all ages are at risk. The very young, the very old, the very unlucky, the very careless, and then the very sick. And it can occur at home and industry. Compromising factors: alcoholism, epileptics, psychiatric illnesses, and other medical cases associated with homicide and suicide. Somebody, I think in Nigeria recently, somebody tried to kill himself. It was not a common thing in Nigeria, suicide. But the anatomy of the skin, of course, we all know the skin has the epidermis, the dermis, and the subcutaneous tissue. I will try not to bore you with much of the details of the histology, but rather to talk about the gross. You have that's the epidermis there, and the one of this is the dermis, and then the yellow one is the subcutaneous layer with fat and all that. Blood vessels, the sebaceous glands, sweat glands, and all that. They get to the dermis, and then the ducts get to the pores get to the epidermis, and all that. These are nerves. Please permit me to go on so I don't delay. The dermis is mainly cellular, unlike the epidermis that is acellular. There is mainly the capillary dermis and then the reticular dermis. And this is important because of the classification of death, of course. Then you have the subcutaneous tissue with skin appendages, sweat glands, and all that, getting down to the subcutaneous fat. What are the causes of burns? Thermal burns are the most culprits in this environment, either as flame or flash caused by kerosene explosion, petrol explosion, gas explosion, naked flame, firewood, and all that. Hot water burns any liquid, hot water, hot grease, steam, hot tea, hot air, and all that can give you scars. Contact with hot object, that's called contact burns. Any hot object, poisonous pipes, pressing iron, electric heater, and so on. Chemical burns, strong acids, alkalis, corrosive materials. There's a conversion of chemical energy onto thermal energy, and they cause damage. Electrical burns, the low, high, and ultra high voltage. The lightning is the ultra high. The high voltage will have, along our roads, usually the lines are horizontal, while the low voltage, the low voltage are usually vertical. And of course, most of the low voltage are the ones we can get through the home appliances. Then the static electricity, which is recent in the sense that handsets are not too long, have not been too long with us. We have discovered that some patients present with burns from handset on exposed petrol. They get a call, and the moment they get a call, there is an explosion. We have not explored the mechanism yet, but we just assume that we started electricity off some waves and all that. Radiation,
is there any way,
any therapy and all that. Radiation burns, some burns too. Some burns,
someone just injection to be very seriously ill.
The road traffic accident,
like that.
friction burns.
They say the doctor will come and look at them, shake their head.
Heat transfer, apparently, cause where there is
It's
transfer
more than
of heat
100%.
from
This patient will
the
not make it because
water
these
object
lungs here and
to
their
a
back
cooler
was quite fun. But the other
the
ones
skin,
were pink.
when the skin
Very
touches
recent patients.
an object that has a
So
higher
there is-
temperature, there is a transfer of heat.
Yeah,
There is a transfer of heat onto the cooler one. And that is exactly what we are talking about. The rate of heat transfer and so on depends on the temperature, depends on the agent, and so on and so forth, and the duration of contact. Duration of contact. If you put your hand in very hot water and quickly remove it, you may not have burns. But if you leave your hand there for more than 2 seconds, or maybe 5 seconds, you have some burns. So contact with the object, and that is why patients with epileptics and unconscious patients often have deep burns, because an epileptic will not know when he has fallen into fire, and the object that touches the fire will remain there for a long time before rescue comes. So they often have very, severe multiple burns. Pathophysiology of burn. It does not matter where the burn takes place. The local and systemic inflammatory reactions are involved. Somebody may have a burn on the limb, the lower limb, but the systemic effect goes round from the head to the toe. So there is a disruption of capillary barrier and damage to the intercellular cement that binds the cells, especially the epidermis and the dermis. This leads to the fluid and plasma exudation, and fluid exudes from the dermis, leaking to the epidermis, and that is responsible for what you have as blebs or the vesicles somebody was referring to earlier. Now, there are local changes that take place. A surgeon called Jackson described in 1970 that when there is burn, that there is an area of maximum impact, and then concentrically, and I go out, the degree or the pathology gets less until you get to the normal skin or normal part of the body. For instance, the very core area which has the maximum impact is called the zone of coagulation. This is where, in this zone of coagulation, there is already tissue death because of the heat. Then as you go outer, you have the zone of stasis. In the zone of stasis, there is this tissues in the zone of stasis. Tissues in the zone of stasis are potentially salvageable if there is prompt treatment and adequate treatment too, for that matter. And then the periphery is the zone of hyperemia. The zone of hyperemia would always recover, except there is infection. So you have the zone of coagulation, the zone of stasis, and the zone of hyperemia. Now, if somebody has about 20% burns, the zone of hyperemia may involve the entire part of the body. To tell you how severe burns can be. Systemic changes, we talked about fluid exudation. Now, fluid, there is exudation of fluid around the burn area, and to a lesser extent in tissues outside the area, a disruption of permeability, which I talked about earlier, and then this is caused by mediators, which include the histamine, serotonin, prostaglandins, platelet bulldogs, complement components, and so on and so forth. These are, agents that are released that are responsible for the systemic effect we have in burns. There is loss of plasma because because of vasodilatation. There is vasodilatation, and there is exudation of fluid leaving the vascular system, fluid and protein leaving the vascular system and entering the interstitial system, entering the cutaneous system, and so on. So there is then loss of fluid from the vessels. There is loss of fluid from the vessels to the cells and outside the cells. to the subcutaneous space and to the intracutaneous space, so that the patient is left in dehydration. And this takes place during the first 8 hours. It's worth the first 8 to 12 hours, and then tails off the next 48 to 72 hours. Right? That is the tissue damaged by burning may produce breakdown of intercellular ground substance, which contributes to rapid increase in colloid osmotic pressure of the interstitial space, because there is pulling of protein from the vessels to the interstitial space. The protein in the interstitial space now helps to pull out more fluid from the vascular system, thus worsening the situation in the vascular system, and at the same time worsening the situation in the interstitial space, causing more edema. The renal system, there is pre-renal oliguria because of hypovolemic shock, acute tubular necrosis from myoglobinuria, hemoglobinuria, and sepsis. When there is extensive muscle injury in electrical bones, there is a release of myoglobin, and this is, as it enters the kidney, it is deposited at the tubules and can lead to tubular necrosis. The same thing with hemoglobin when there is intravascular hemolysis, and then sepsis. The metabolic response is worse. There is massive stress response characterized by hyperdynamic state, which is associated with increased oxygen requirement and carbon dioxide production. That's why patients with burns are always given oxygen. It helps them to recover. There is increase in catecholamines, cortisol, and other stress hormones up to 10 times. The hypercatabolic state with glucose intolerance, increased gluconeogenesis from muscle and lipolysis, muscle wasting, and nutritional failure are common. There is increased antidiuretic hormone secretion, water retention, and possible hyponatremia. Alright? Pain, alright, in this hypermetabolic state above is amplified by pain, sepsis, and heat loss. Pain, sepsis, and heat loss. So, giving patients analgesics and treating infection and covering patients to prevent heat loss are all very necessary in bringing your patient back to life. Respiratory system. Where there is facial burns or inhalational burns, smoke is inhaled into the lower respiratory tract. And also there is thermal injury to the upper airways leading to edema. I said earlier, the swelling and edema that takes place on the skin also takes place in the trachea and upper respiratory tract. Now this will lead to, because it's a tube, it will now lead to narrowing of the lumen. Then there is maximum effect within 24 hours, subsiding after 4 days. The surgical effect of circumferential full thickness burns around the thorax leads to restrictive lung effect. If there is full thickness burns around the chest, called eschar, the same effect it has on the limbs, preventing vascularization because of compartment syndrome, will also take place on the chest. It will prevent proper excursion. And unless escharotomy is done, the patient will have respiratory restriction. So all these will lead to acute lung injury, acute respiratory distress syndrome, metabolic consequences will lead to increased production of carbon dioxide, bronchopneumonia, and all that. In cardiovascular system, there is massive loss of plasma and water from the intravascular space, which may lead to hypovolemic shock. A patient with 50% bronch, for instance, can lose a third of the total volume within 3 to 4 hours with the hematocrit rising. When a patient comes in and you do a PCV, the hematocrit is always very high, and that is false because of loss of fluid. If you rehydrate the patient and repeat the same thing within 2 days, you discover that the body would have the proper hematocrit value. That's myocardial depression induced by the inflammatory response, and then hemolytic anemia. Don't forget that the patient, there is 1% red cell mass loss per percentage of bones, especially full thickness bones. For 1% full thickness bones, there is a reduction of 1% red cell mass. For patients with sepsis, there is further reduction in hematopoiesis. Recurrent dressings and bleeding also add to anemia. So you find that your patient, and of course, don't forget the loss in the gastrointestinal tract. I talked about the Collins ulcer, the stress ulcer. That also leads to, worsens the patient's, hematological state. All right. Gastrointestinal system, there's high incidence of stress ulceration known as Collins ulcer. That's hematemesis. There is paralytic ileus with severe burns. There's a stating the use of nasogastric tube aspiration. I said earlier that we feed patients early. But patients who have severe burns, we don't feed them because they will have paralytic ileus. So we don't feed them early. Now, how do you classify burns in terms of death? Classifying burns in terms of death, we have the first degree burns. First degree burns is like the sunburn, which the whites often have when they go and sunburn themselves. Now, this heals very fast. Within 3 to 5 days, there is no scarring, and it's not much discomforting. Then you have the second degree burn. Maybe I should, okay, yes, I'll have a photograph to show you later. Second degree burn, this is part of the dermis. The reticular dermis is involved. And it involves the epidermis and part of the dermis, the papillary dermis. It is thin-walled, there will be thin-walled and fluid-filled blisters. It appears pink. That's the difference between full thickness and superficial burns. Superficial burns are always pink, moist, soft, and very tender. They are pink, that is the reddish, sort of. Moist, soft, and tender. They heal within 2 to 3 weeks. So even if you don't know the depth, and the patient's wound begins to heal within 2 weeks, then know in retrospect that the patient had, superficial burns. They heal by epithelialization. Yes, epithelialization, epidermis, epithelial cells rise and migrate from the skin appendages, the blood, the hair, the sweat glands, the skin, the hair follicles, and all that. So skin epidermal cells migrate and rise and very soon cover the burn surface in superficial burns. Okay, that's the tool I'm looking for. Now this is first degree burns. This is the area, just a little bit of the epidermis is involved. This one heals without much pathology. While the second degree burns, there is epidermal damage and papillary damage. But you see have all these appendages from where there is re-epithelialization. Now you have another entity. This is the full thickness burns. This is the full thickness burns. Also part of, this is a third degree burns. Full thickness burns is third degree burns. The entire skin and the entire epidermis and the dermis are involved, and down to the fat. Then you have the fourth degree burns, where the muscle, the cartilage, and all that are involved. So that is the American classification. I think we can make do with that. All right. This is a patient who had the full thickness burns. Now that superficial burns, you can see the redness. You can see the redness. But suffice it to say that superficial burns will be converted to full thickness burns if there is infection. There's infection. So sometimes when the patient presents late, it's difficult to know whether he had superficial burns or full thickness burns. Now, this is the vegetables you are looking for. You are talking about this ones. Yes, if this is found in a patient that is, that is the entire area looks neat, you may leave it. But if there are some ragged, infected part of it, like here, these parts are infected and all that. If you leave this, it will get infected. So it's advisable that you rupture it and dress it properly. Rupture it and dress it properly. Alright, third degree burns, I've talked about it. In third degree burns, there's full thickness burns. There is loss of capillary network of the dermis. There is the burnt area looks whitish or leathery. That's another way, a way to differentiate the full thickness. It is whitish, leathery, or sometimes appearing brownish, and then it looks hard, thick, just like leather. It's not moist, it's dry, it's whitish or leathery, and then it's anesthetic. You use a pin or needle, the patient does not feel the pain. That is full thickness burn, because the nerve endings have all been burnt off and the patient will not feel any pain. These type of burns, if you recognize them early, then don't wait for any healing, because it will not heal by visualization. It is going to heal by wound contraction and then end up with contracture. Those are the ones that will have keloid. That's the ones that will come back later for surgery, because there would be contracture and deformity. So early grafting, skin grafting is done. Early skin grafting is done. And patients who have full thickness burns, they fare worse because the metabolism is worse. Unfortunately, in our environment, these are the same patients who, either because they don't have the money or because they think they shouldn't go for surgery, they avoid or refuse surgery, and they stay on admission for 3 months, 4 months, and after they have gone, after the wound has healed, they end up with ugly scar and come back later for surgery. Some patients go with wounds not properly healed. These are the same wounds that may stay for 10 years or 15 years and end up with Magellan's ulcer, malignancy. Leathery, just looks like leather, brownish, whitish, and all that. This is another one. This one is, you could beat a drum on it. You could almost be, it was sounding like a drum, sort of. It was so thick, so very thick. This patient had burns and they wanted to remove her clothes, because that's what they say. She refused her clothes to be removed. And of course, the clothes burned the skin and then ended up with it. She couldn't make it. 4th degree burns, I've talked about that, when the muscles, cartilages, and all that are exposed. This is a full thickness burns. This is blood vessels and all that. Alright, now classification by size. Classification by size. Dr. Wallace described a system of estimating the extent of burns in a patient. And he said approximately the size of the patient's arm is 1%. And based on that, Wallace's rule of 9 was propounded, and it has helped the management of burns. I'm sure anterior chest is usually rule of 9, not rule of 18. With them medical students, it's not rule of 18, it's rule of 9. The anterior chest wall is 9%, anterior abdomen is perineum. Yes, trapezius figure is 1%. Then at the back, the posterior chest is 1%. Then the lower back is 9% rather. The entire right upper limb, left upper limb, 9% each. Then the thigh, anterior and posterior, is 9%. The leg and foot is 9%. The the same thing on the contralateral side. Then the perineum is 1%. They put all together, it adds up to 100%. Now, this is a rough assessment of patient excess of blood. Many other people have tried to define or rather refine it and make it more exact. Look at rather try to use the different parts of the body and make it sharp. Depending on age, for instance, for 0 to 1, for children, so children have bigger head and smaller limbs. Children, head and neck, 9%. One of the thighs, 2 3/4. One of the leg, 2 1/4, 2 2.5. And then it goes on like that. But this looks cumbersome to memorize. Patient management. In the absence of emergency, we use rule 1 rule of 9. For academic purposes, those going for postgraduate exams must know Lund and Brother method. Burn severity depends on the extent of burns, the depth of burns, and the location of injury. For instance, facial burns. Facial burns, the original burns have worse prognosis than elsewhere. Age of patient. The very young, the very old have worse prognosis. For instance, it is said that if you add up the age of the patient to the surface area, if it's up to 100 and above, prognosis is poor. Prognosis is poor. Presence of relational injury, etiological agents, coexisting illnesses. The patient has HIV/AIDS, full-blown AIDS. A patient will have problem with wound healing. Patient with diabetes is not controlled, and so on and so forth. So coexisting illnesses. This is just classifying major burns as burns between 20% and above. Let's leave this and go on. But I want to say at this point that what qualifies a patient for admission in an adult is if the patient has burns up to 15% and above, or of superficial burns, or if it is full thickness burns of 10% in an adult, please admit the patient because it's full thickness burns. Or if a burn affects the head and neck, the face, the perineum, so in order to avoid the complications, please admit the patient. Well, these are prognostic factors I talked about earlier. Management. Now there is a pre-hospital management, that is what happens at home. This is where we need the media to really emphasize. What do people do when they have burns at home? Stop, drop and roll. There's no use running out with burns on your clothes. You are running to meet somebody and the person is running away from you. The best thing to do is to drop on the ground and roll. The moment you do that, that puts some fire. Drop it on the ground and roll it. I don't want to demonstrate that yet. That puts off the fire. And then puts off the fire. And then the next thing is to remove all clothes. Burnt clothes. They may not have flame, but the heat is still there. So it is all removed, and then cool the patient, the burnt area by irrigating or immersing in water. Somebody asked the question of patients with almost 100% burns. Well, of course, in a hospital setting, we know that such a patient will not survive. So what are you aiming at? But patients who have burns that you want to help, yes, make sure that the burnt area is cool for at least 20 minutes. I've explained the usefulness earlier. Provide pain relief. Well, at home, you will not be able to provide that. But after you have removing the burnt area and cooling the place, it will help the patient to be more comfortable. Then cover the patient with any clean cloth. Because they don't expect you to have sterile cloth at home. Any clean cloth, and move the patient to the hospital. Avoid use of raw eggs, fermented cassava, salt, other native preparations, leaves, sand, so on and so forth. All these ones will, even gential violet, yes, I must mention this at this point. Applying GV does not help these patients because they come in, all you see is just the color of GV. You cannot assess the depth. Sometimes the GV is there coloring the wound, and underneath the GV you have pus. So avoid application of GV. Please. It is not a good treatment for burns. Then, when you get to the hospital, what do? The initial survey, which I talked about earlier, ABCD, the advanced trauma life support, ABCDEF, airways, you must make sure the airway is patent and there is good cervical control. You must make sure the patient is breathing well, there is adequate chest expansion, make sure the patient is not suffocating. You must make sure that, there is adequate circulation, no bleeding points anywhere. And if there is, you can, stop the bleeding. The peripheral pulses are peripheral. Can I go on, please? Yes. The peripheral pulses are palpable and good. D stands for any deformity, any disability. Expose the patient. Is there a fracture, concomitant fracture? Is the patient awake? Is he alert? AVPU, have to. Is he alert? You call him, he answers, or he doesn't answer? Or does he just respond, call his name, he's able to answer his name, but doesn't know where he is? Or is he only responding by, pinching or painful response, or no response at all, or responsive? AVPU, just a rough estimate at the primary survey before you go to Glasgow Coma scale and all that, which is secondary survey, to determine the extent of, neurological, cerebral deficit. Then E, expose the patient, determine the extent of burns, total body surface area. You determine the total body surface area. Please expose this patient from A to Z. Sometimes you find that a place is just dark, and you think it's nothing. By the time you come tomorrow, the place has peeled off. That's part of burns. So the assessment of burns is very dynamic. The casualty officer will assess his own, the resident will assess. By the time consultant ward round and the wound is exposed again, you discover this place is burnt, this place is burnt. So it's either less or more by the time you do the conclusive assessment. And then F stands for fluid resuscitation. Fluid resuscitation, we'll quickly go into that now. Any fluid available can be used. It is better to start something. In fact, when we talk about C, the circulation, you are advised to set up 2 lines. You set up 2 lines, quickly insert a fluid on one of the lines. The other line, collect blood for investigation before you put up a fluid there too. Now, mostly we use Ringer's lactate. If you don't have Ringer's lactate, you have normal saline, please use. You have dextrose in saline, please use, but not allowed for a long time, except maybe the following day because of dextrose, just to give patients some dextrose and all that. But the best choice is Ringer's lactate, which is closest to the body's composition. The first 8 hours is very important. The first 8 hours is important. And in fluid replacement, you take cognizance of the time of burns, not the time the patient gets to the hospital. And Parkland's formula is used. Parkland's formula, 4 mils of infusion, multiplied by patient's weight, multiplied by the percentage total body surface area. An earlier question came about determination of patient's weight. We just assume. If it is pediatric patient, or these are old method we learn when we're in university. 2n plus is it plus 2 or 4? Yes, 2n plus 4. But I hear it has changed now. Yeah, so that's it. All right. But where the patient can be weighed, please weigh the patient. Now, your success depends on appropriately adjusting the patient's need, patient's fluid need. How do you assess patient's fluid need? Or rather, that the patient is making enough urine. I mean, that the patient is adequately resuscitated. Urethral catheterization and monitoring of the patient's urinary volume and color. Both the color and the volume of urine are important in adequately resuscitating your patient. Of course, you also use the vital signs to monitor your patient, so on and so forth. Now, in the first 24 hours, the first day of presentation, you give a patient half a calculated volume, 4 multiplied by weight multiplied by percentage bonds. Give the patient half of that in the first 8 hours, and then the next 16 hours, give the remaining half. The following day, you add some dextrose, then you add the patient's daily requirement, and then in your calculation, you are no more using 4 meals, you use 1.5 meals. Mind you are going to add the patient loss of the previous day and all that. But the first 24 hours is very important in your calculation. We don't use colloids, we use mainly crystalloids. Colloids does not have any necessary advantage. In fact, colloids worsen the case for the patient because in the first 24 hours there is still loss of fluid. The fluid you get from the colloids will be lost to the interstitial space, and there, by osmotic, this thing will also attract more fluid from the vessel. So it doesn't have an advantage. It doesn't have an advantage. So crystalloids have been used over years, and crystalloids are the 8 things. Alright, talk about nuclear history, then investigate, examine. During your examination, please remember, if it's a case of trauma, make sure that there is no fracture, make sure that there is his spleen is not ruptured or liver is not ruptured, make sure the patient is conscious, and so on and so forth.
I want to start
Now,
my questions,
management.
comments by thanking Dr. Fije.
We talked about washing the patient with water or normal saline. If you can't get normal saline, please use water to wash the patient, remove normal saline. If you can't get normal saline, please use water to wash the patient, remove dirty tissues and remove blisters. Then dressing will be open. In open dressing, sulfur 2 mesh is used, or silver, sulfadiazine cream, or aqueous silver nitrate. Any of them could be used. But we use mainly povidone iodine ointment in this hospital. Occlusive dressing. In occlusive dressing, the patient is covered. After all the applications, patient is covered with gauze, with ganji, and with crepe bandage. The advantage of that is to prevent infection. The advantage of that is that to prevent pain too. If a wound is exposed and it is partial thickness, the patient is uncomfortable. Bedsheet touching the wound will cause pain. Breeze touching the wound will even cause pain. So closing the wound gives the patient some comfort, adequate comfort. Then there are other synthetic wound covers like Bryovane, Transite, and all that, and Integral. This can be used also to cover wounds, especially in the theater. Surgical management begins from venipuncture, debridement. Debridement is the same thing as escarectomy, which I talked about earlier. You are cutting off dirty tissues. That's escarectomy. Escarotomy, making a cut to prevent compartment syndrome. Vascular or venous cut down, skin grafting, cadaveric skin before now has been used for skin grafting. initially. The patient presents with severe burns and there is not enough skin. There's not enough of the patient's skin to cover the skin, to cover the wound. You could use the cadaveric skin to cover that wound. It should be rejected within 2 weeks. And by the end of those 2 weeks, your patient would have stabilized, loss of fluid would have reduced, that then some epithelialization would have taken place, and the patient would have been stronger. Now the same thing using a relation skin. You can use a relative skin to do the same thing, and it will be rejected within 2 to 3 weeks. By that time, there is some patient would have stabilized and all that, and then you now do the proper skin grafting. Within 6 weeks, you can use a burnt skin that has healed to graft a wound. You can use a burnt superficial burnt skin that has healed. You can use it to graft a wound, or a site you used earlier to graft a wound. When it heals within 6 weeks, you can reuse that site, that skin, to graft a wound. Now, we're talking about fasciotomy or escharotomy. This is how you can do it. On the chest, if the patient has constrictive chest burns, you can make both vertical and transverse incisions. This is the limbs. You can get it down to the digits. You can get this cord down to the digits, and so on. This is an example that I showed you earlier. Supportive therapy, physiotherapy, occupational therapy, nutritional supplementation, parenteral nutrition, vitamins, blood transfusion, psychological therapy. This is very important. This is very, very important. Remember that these patients were breadwinners. These patients must have lost their properties in the bones. They have lost their, loved ones in the inferno. And looking at their skin, sometimes when the patient looks at his face or her face, he gets so angry because the beauty is lost and many things. So they need to be supported psychologically. So clinical psychologists and psychiatrists are often invited to help the treatment of these patients. Many of them commit suicide. Many of these patients commit suicide. So you have to avoid that. Chemical burns. Whatever is the cause of chemical burns, please, irrigation is the treatment, initial treatment. Whatever is the cause of the chemical burns, whether it is acid or alkali or whatever corrosive, use water. Don't dilute acid with alkali. No. Just use water. Then after, you can do excision and skin grafting, as the case may be. Electrical burns, don't use water. Avoid water in electrical burns, because that will worsen the situation. But pull the patient out of the site. Make sure you don't have any direct contact with the patient with electrical burns. Use an object or a cloth to pull out the patient first before you do any other thing, to help the patient. These patients were born with, alright, sorry about this picture. The victims of the electrical high tension, this thing we had about 2 years ago. These limbs were amputated. They couldn't make it eventually because there was a lot of delay in getting a consent for the amputation. So there was a lot of delay. But amputation is a treatment modality, surgical treatment modality in patients with severe burns, especially electrical burns, or burns where there is a compromise of plasma supply. This patient had inhalational burns. You can see the lips, and it's already on oxygen. And if we notice that the respiration is being compromised, intubation will be done. This patient was managed in intensive care unit. Alright, so inhalational burns, I don't need to go far in discussing inhalational burns. Anybody in peripheral hospital who finds a patient with inhalational burns, please refer such a patient, because you may not be able to handle such a patient in your center. You will require intubation, you will require tracheostomy, and so on and so forth. Please, but the important thing is, in the interim, you can give the patient oxygen, 100% oxygen in a non-rebreathing bag. Humidified oxygen in a non-rebreathing bag is what is the treatment in the interim of inhalational burns. All right. Complications of burns, hypovolemic shock, wound infection, renal failure, hypertrophic scar, keloid formation, depigmentation, contracture. In depigmentation, some people after years of burns, they still find that the area that was burned is no more pigmented as the other entire skin. Can't do anything about it. Just hope that with time it is going to repigment. Contracture, depression, marginal ulcer, and of course death. Somebody else will talk about prevention. Thank you for listening.
We'll take questions.
I want to start my questions, comments by thanking Dr. KJ for the lecture. Thank you for your lecture. A comment please before I start the question. I know that one of the reasons why this symposium is being organized to help us rejuvenate our interest in taking care of patients who are affected by burns. I also expected that in your first lecture, which was management of burns, you became experienced that obviously you would have given us some statistics. Because it's one thing for us to come to lecture, to listen to a lecture like this, and to go back and probably be practicing the same somehow primordial way of managing of patients in this form. I made some forms of statistics. Let's see what is being done, what is expected to be done, and what are the areas of improvement. But I know that, I'm sorry, I am Dr. Joe from the City Department, LPD. I said that the statistics we get in our intensive care unit for burns, our burns seem to give us the worst statistics in terms of the mortality. If you have 100 patients being admitted in intensive care units, you lose over 99% of them. So that kind of statistics I expected us to get today so that we evaluate our practices and see areas that we have inadequacies and areas we need to make improvements.